I think we'll probably move on to the next. So I'll introduce Edwin. We'll do our questions just before the break. So Edwin is going to speak to us about expanding mitral TEER treatable anatomies. What can our current devices do?
Anita. So, you know, as you all know, and we just heard from Anita, mitral TEER really is the predominant transcatheter mitral intervention. So we're going to do a little bit of a more deeper dive just to see what our current status is with mitral TEER. These are my disclosures. So we'll first talk about how we define anatomic suitability or not suitability with a couple of brief case examples about why this is always a case-by-case discussion. Talk a little bit about the current data on outcomes in suboptimal anatomy, and then very briefly just introduce where the unmet needs are still for M-TEER. So if we think about where we are in 2023, of course, we've come a long way since the original Everest data and Everest trial, where, you know, anatomy was really, should have been considered very optimal at that point, to a much more complex grid of factors that really allow us to decide, is this a great case, maybe not such a great case, or a terrible case? Most of the time you hear people talking about anatomic eligibility in this context, this kind of green, yellow, red categories. And then depending on where you practice, you may find that there's actually a different balance of how many patients fall into each category. I think what's being talked about more and more now, of course, is this orange category, because sometimes you're surprised there are these maybe more difficult yellow cases that end up being much harder than you think, and then ones that you think are terrible red cases that actually end up going much better than you think. And then I think really from our point of view as clinicians, what really we want to know is who fits in that truly, truly ineligible category. There's a few different consensus papers that have been published and other papers about what sort of risk factors might actually deem someone not suitable. This is one that I like a lot. It summarizes a lot of the really important factors. And you can think about it in terms of factors that may either impact the risk of success, risk of stenosis, or other factors that are, of course, really important to TEER. But again, are all of these individual factors really a true red flag that tells you it absolutely can't be done? I have a few case examples to show that, you know, sometimes it is still possible to treat this type of complex anatomy. So for example, this is an example of a commissural lesion, so anatomically considered more complex, but with adequate, you know, device positioning and leaflet grasping, we're able to eliminate MR in this situation. Split and multiple jets are really annoying to look after. So you can see those two holes that are sort of wide apart, sparing the central part of A2P2 in this mitral valve. But again, with well-positioned devices, you can actually potentially get a good outcome without significant stenosis. Very severe prolapse, bi-leaflet pathology, Barlow's. This is a patient in cardiogenic shock who we treated. There's still a little bit of residual MR, but dramatic reduction in someone with very, very high, really prohibitive surgical risk. Here's just a quick example of a cleft that we always worry about, an MR that extends into the cleft. Sometimes you need more than one device, but again, if you're pulling the tissue in the right vector, sometimes you can actually get a great result. And then MVA ends up being a really important stenosis risk factor. And I put smallish because I think all of us still struggle to know what's the true hard cutoff for when it's actually too small. This was one that we were really not sure about, but there weren't any other options. We were still able to actually get a really good reduction with very little gradient. No or poor imaging by TEE. So even though these look like TEE images, these were actually cases that were done completely with 3D ICE, so that's definitely changing our landscape. And then no femoral access. So this was a case from when I was still in Toronto with Neil, and this was one of our transjugular cases. So again, always a case-by-case discussion. So it's nice to, of course, see these, you know, random cases, but are they really just a one-off? So what does our current data actually say? So fortunately, we have a few observational registries that give us some idea of what real-world practice looks like around the world. So Expand G4 is the first one I'm going to talk about. So this was multi-center international registry, more than 1,000 patients. Again, real-world kind of practice. These results are the overall cohort, and so I just highlighted the important things, which were great reduction in MR, greater than 90% of people were less than mild, and good symptom reduction both by NYHA class and KCCQ change. within this registry, there were a small number, but still a fair number of patients where there was a concern for risk of stenosis or inadequate reduction. And then how did those patients actually do? So if we first look at risk of stenosis, so they define that as basically having severe MAC or calcification, prior annuloplasty, or small MVA. And in this situation, actually, we saw in this registry that the results of TEER were still very good. So still very good reduction in MR, and the gradients actually were not too bad. So on average, about 5. Of course, some higher, some lower. Not surprisingly, most of the time, smaller devices were being used, although still the wide ones. So the NTW, and most of the time, just one device. Symptom improvement was still very good in this small but important patient population. And then in terms of risk of residual MR, so again, those are those leaflet complexity factors that we think about. In this situation, not surprisingly, the outcomes in terms of MR reduction are a little bit more attenuated, but still 75% of people were able to have mild MR or less at 30 days. And then maybe no surprise here, more clips were being used, so in median were 2, and then more likely these longer, wider clips, so the XTW. And again, symptom improvement was good in this small population. In terms of CLASP 2D, so there was a randomized cohort for CLASP 2D, which was the pivotal trial for the Pascal device, but also this registry cohort. And then within the registry cohort, some were placed in that cohort because of anatomically complex disease. And you can see here the distribution of why that was deemed the case by the eligibility committee. And then how did these patients do? So again, good reduction in MR, maybe not as good as in an optimal anatomy, but still about 60% got mild or less, and then greater than 90% were moderate or less, so whether you call that a win or not, you sort of have to decide again case by case, but still pretty good reduction. And then the last registry I want to mention is the Choice MI registry. So this was, again, multi-center international, almost 800 patients, basically all patients that were high to prohibitive surgical risk with suboptimal TEER anatomy. So these patients were really being screened for TMVR studies or other devices, but a large number did screen fail, and about 200 of them had this bailout TEER. And how did those go? So again, similar to what we saw in that anatomically complex cohort, so the amount of people who were actually able to get mild or trace MR was obviously a lot smaller, but still a very good proportion with moderate or less. And considering the patient population, actually it doesn't seem too bad. They also looked at the outcomes of these patients, and they seemed to do better than medical therapy, but of course, it's observational and there's selection bias at play here. So is TEER perfect? Of course not. So there's still definitely unmet needs. And when I look at a valve and screen a valve, I put this example up because this is one of the worst ones I think I've ever seen. It sort of highlights a lot of these important factors that I think really put us in that far red zone. So really when there's not enough tissue, then no matter how much pulling you do, you're just never really going to get coaptation again. Tissue quality ends up being such an important factor for success. And then very clear stenosis risk factors or baseline stenosis, like in this situation. So in summary, an anatomy that's treatable by MTEER continues to expand. We see reasonable outcomes in these observational registries, but of course, there's still this big unmet clinical need in those who are truly ineligible. Thank you.